So thanks, Jamil, and thanks again to the organizers for coordinating all this and inviting us to present. So I want to touch on the fat transfer methods for achieving similar results on a longer-term basis, perhaps. I think in addition to what Jamil was saying about the importance of the periorbital area, visual tracking research has actually shown that we spend most of our time looking at a face at the eyes, looking at the eyes. So another reason that it's important to try to get it right. These are my disclosures. So why do fat transfer as opposed to synthetic fillers, which are off the shelf and can have very limited downtime? Well, the advantages are that it's natural, which resonates with with an ever-increasing, I think, percentage of the population. It's durable. There's no chance of a Tyndall effect or bluish effect beneath the eyes. There's a possible stem cell effect, and we'll touch on that a little bit later. It's easily combined with other procedures, as I'll show. It's inexpensive, perhaps the best ROI of anything in my practice besides a blade handle. You can get all the equipment that I'm going to show for probably under $1,000. Overall, it's pretty high satisfaction as well, and patients will travel for this. So disadvantages are the downtime. It can be a week or two. I usually tell patients to expect 2 weeks of social downtime. Imperfect predictability, a range that's fairly broad, but overall about a 32% retention and a fairly low percentage of patients asking for a touch-up in my practice. It's more challenging in thin patients who are older, and patients of unstable body weight. It's living fat tissue, so if they're going to gain weight later, it's going to grow in their face as well. It's also, because it's durable, we want to make sure we don't overfill it and create irregularities. Like with any injectable, there's an intravascular concern, and so we want to avoid the intravascular or the neurovascular foramina. So I won't belabor the technique, but it's basically that adapted from Coleman, and as I learned from the Glasgow during training, and gentle handling, centrifugation is what we use. There's really been nothing that's shown superiority to this. And then infiltration with 0.9 and 1.2 millimeter cannulas. I typically use only the 0.9 millimeter cannula in the superficial, in the infraorbital region, and 1.2 for everything else, and superficially in the infraorbital region for the 0.9. So, of course, in multiple planes, small amounts to try to make sure you get maximum viability through vascular ingrowth. And we actually do probably 5 passes per 0.1 cc for the superficial infraorbital rim, and then 3 passes for most other areas. And of course, injectable lamb withdrawal, especially in those regions of neurovascular foramina. Just basic markings that we'll use for a typical patient for fat transfer, superior and inferior. So the superior and inferior, obviously, periorbital area, and we've marked the dots for the maximum depth of the hollow and infraorbital region, and blending into the temples and anterior and lateral cheeks. Quick video, if you don't mind starting that, just showing the approximate speed of injection. Palpating the infraorbital rim with our non-dominant hand to try to protect both that and the globe behind it. Usually a little bit of a stutter step to get in the right position, just a couple of passes, and then injecting on withdrawal and marching across the infraorbital rim as we go. It's important to only inject the infraorbital rim from the inferior access point, so about a mid-pupillary line inferiorly in the anterior cheek, rather than from the lateral canthus, because others have shown some irregularities from the lateral aspect, from the lateral canthus approach. It's probably because of the orbicularis retaining ligament, which is not traversed when you go from the lateral approach as opposed to from the inferior approach. Next slide. You can go ahead. Yeah, thank you. So I won't run through this video, but basically this just shows the access from the approximately mid-pupillary line for the medial supraorbital access, and then from the lateral canthal area for the more lateral tapering, and then we'll blend it in with the medial approach and approximately the region of the mid-pupillary line. So I just want to go through a few examples of patients which show kind of a spectrum of atrophy that we can encounter, and the amount of volume that we might choose with this particular technique, so that those who haven't done it before can get kind of a baseline starting recipe. So a patient who comes in with mild atrophy, probably in early 50s, who just got 3 cc's along the infraorbital rim, including 2 medial and lateral deep and 1 superficial, and then blending it with a typical amount in the anterior and lateral cheeks, 3 and 2 cc's, a little bit in the lateral canthus. Oblique view. No blepharoplasty performed with this. Patient a little further along the continuum with moderate atrophy. She's actually in her late 50s, which is fairly typical. She had an upper blepharoplasty combined with fat transfer. And so she had upper orbital rim, augmentation as well as inferior, and 2 cc's in this case superiorly, both 1 medial and 1 lateral, 2 in the temple, and then again 3 along the infraorbital rim, and then typical amounts in the anterior lateral cheek. 3/4 view. And then a little further along the continuum with advanced atrophy, this patient could be in her mid to late 60s, but she's actually interestingly the same age as the previous patient, but more advanced atrophy, and notably I think the hollowing that she gets in the superior periorbital region with near complete exposure of the upper lid and recession of the upper lid into the orbit. And so in order to achieve that amount of augmentation, we use 4 cc's for the superior orbital region and 4 inferiorly as well. And interestingly, I think you can get a little bit of a pickup of the tail of the brow with the lateral augmentation blending into the temple. And that might be because of kind of a pendulum effect, where the skin envelope might be analogous to the pendulum string, and as you fill, then it's not going to extend, hopefully, and rather just elevate anteriorly. Male patients, of course, we want to be more conservative unless they're wanting to be feminized. And in this particular patient, lower blepharoplasty with just a little bit of fat along the infraorbital rim, nothing in the anterior lateral cheeks. A little bit older gentleman who had a lower blepharoplasty as well. In this case, we did just a little bit of fat in the anterior lateral cheeks in order to rejuvenate him but not feminize him. So what enhancements might we use in the future? Well, PRP has shown some promise. A study by Sasaki showed some increased retention through use of PRP mixed with the fat, or injected into the fat after infiltration, I should say. There may be a trend toward decreased bruising, and I've begun using it. Initially, we used it in older patients to try to make sure that there wasn't any unwanted effect, such as turbocharging or excessive retention. And happily, that wasn't the case, so we're now using it in all patients at about a ratio of 10%. Stem cells are probably already playing a role. Those of us who do a lot of it see improvement of the skin quality after fat transfer, and we're beginning to see evidence of why that might be. An animal model has shown increased dermal thickness through neocollagenization of the dermis in the skin under which fat was placed. Also, Tenard has shown some improvement of the skin quality through injection what he calls nanofat, where he's taking what he calls microfat that harvested with a smaller cannula pore size, like a millimeter, instead of a typical Mercedes size pore, which is 2x7, and he considers that macro fat. And further taking that microfat, emulsifying it, and then filtering it back and forth through a Luer lock and getting what he considers nanofat. Apparently that's not shown any viable fat cells, but has shown viable stem cells, and is injecting that with 27 gauge needles and feels that there's an improvement in the clinical appearance of skin. In the article it showed décolleté improvement, but have not tried it myself. I may begin trying it and look forward to hearing others' experience on that as well. So in conclusion, volume loss certainly occurs in the periorbital area, as we've heard Dr. Hessler and Dr. Azaria also mention, superior and inferiorly, and superior periorbital treatment I think has become a newer frontier, and restoration of that volume loss is powerful and gratifying, whichever medium you choose to try to achieve your masterpiece. Thank you very much.